Hello, my name is Belinda Manukian, and I will be talking about the neonatal and pediatric transfusion practice guidelines for today. The objectives for this module is to review the neonatal physiology and erythropoiesis, along with looking at the current guidelines that we have for the various blood products. In addition to looking at the various blood products, there are certain type of manipulations or modifications that need to be done to the blood products, such as irradiating, the use of leukoreduce, doing hemoglobin S testing, actual defining whether or not fresh blood should be used, and what type of anticoagulant. So this will be covered in these objectives, as well as the required compatibility testing that needs to be done for neonates and pediatrics. So as you can see by this picture, the first thing that comes to mind is the way we would treat a neonatal or a premature infant is going to be transfused a lot different than the way we transfuse an adult. So one of the first things we have to understand is what is the needs of these patients. A lot of times these premature infants, less than 2.2 pounds, are cannot take stress onto their systems, and it can result in organ failure. So they have to be very careful with how they proceed with treating these patients. In addition to that, we have to understand the erythropoiesis process for a fetus versus a full-term infant, so we understand this patient population and their needs. When we talk about the neonatal physiology, a full-term infant or a neonate, true blood volume is approximately 85 mLs per kilogram, whereas a premature infant's average blood volume is 100 mLs per kilogram. As you can imagine, over the advancements of science for these past several years, the survival rate for premature infants, that is, those that weigh less than 2.2 pounds, has been improving significantly. So it has brought in new territory as to how we should transfuse these patients. So we're looking at patients whose blood volume is less than 100 mLs, and we're trying to figure out how do we transfuse them. So one of the things we need to look at is why would an infant need to be transfused? And one would be a neonatal red cell exchange situation where you're trying to treat severe hyperbilirubinemia or anemia in babies with hemolytic disease in the newborn. When we look at why we're doing it, one, we're trying to reduce the severe levels of unconjugated bilirubin. And also, we're trying to remove antibody-coated neonatal red cells. And just so that you have an understanding, for an ABO situation for hemolytic disease in the newborn, it is usually mild due to poorly expressed ABO antigens on fetal red cells. The other reason why we might transfuse is a large volume situation. As you can imagine, with the advancement of neonatal cardiac surgery and techniques, we're doing more and more on how to save these babies when they have certain cardiac situations. And it's requiring large volumes of blood products. And again, on the neonate platform, it's a large volume. So a lot of times these transfusion triggers that we look at as to when we should transfuse is very controversial, and a lot of it goes based on clinical opinion and expertise. So it is very institute driven. So what one institute might be doing at one place might be different from another one, but it could be that they're dealing with different type of neonates with various problems. Another reason, and one of the more common reasons why a neonate will need to be transfused, is due to iatrogenic. And iatrogenic is a situation in which you have blood loss seen in the premature infant due to repeat testing being drawn for repeat testing while they're monitoring the patient. And as a result, it results in anemia. In addition to that, you have the anemia due to prematurity, and this results in needing to replace it. So on average, a recent study showed that 80% of preterm babies weighing less than 1,500 grams received at least one transfusion during an admissions. So this is one area that institutes really try to look at, and that is ways to avoid um, how to reduce the frequent need for blood sampling. And one of that is getting rid of non-essential tests, using low volume sample tubes, or using micro techniques in the laboratory. And then, of course, trying to figure out a non-invasive monitoring whenever possible. For us to have an understanding of how the premature infant has the anemia, we need to have an understanding of the fetal and the neonatal erythropoiesis. So as an embryo starts, the hemopoiesis actually starts at the yolk sac. And then after 9 weeks of gestation, it will shift to the liver. And then at the 24th mark or 24th week, it will shift to the bone marrow. A full-term normal infant has a cord blood usually around 19% or 19 grams per deciliter, whereas a neonate of low birth weight will, of course, have a lower level. Fetal red cells have about 53 to 95% hemoglobin F and have a lifespan of about 45 to 70 days. These red cells have a high oxygen affinity, so that the oxygen is obtained from the maternal red cells. Once the baby is born, you will see a situation where the hemoglobin A is replacing the hemoglobin F. And you have a slight drop in the hemoglobin concentration when this switch is starting to occur. So when a premature infant is born who has a very high concentration of hemoglobin F, they usually have a very low hematocrit situation going on. So one of the first ones that we're going to talk about with regards to transfusion guidelines is for red cells. And so the first thing that we need to look at is, how do we treat the premature anemic patient? And one of the things we have to consider is the weight, the gestational age, the circumstances of the delivery, and the maturation of the infant. So different type of products that are used are the allogeneic donations, such as directed donors. You have, in order to reduce blood donor exposure, because as I mentioned, a lot of times these premature infants are repeatedly transfused with small volumes. We utilize a situation where we will use PD packs, where we sterile dock to the mother unit additional units so that we can separate them off into 50 ml bags. In addition to that, we will take just one PD pack and then pull off syringe use. And usually you're requiring approximately about 20 to 30 cc's of, or 20 to 30 mLs of blood being pulled off from these PD packs. When warming, it is necessary to warm red cells when we're talking about a large volume, like in a cardiac patient, where they're taking the child or the infant to a cardiac surgery. You will want to warm them up when they're receiving large amounts, but it's not necessary when we're receiving small amounts. Here is a list of the guidelines. This is actually from the University of Florida at Shands Hospital. And this gives you the dosage that you would use, so approximately 10 to 15 mLs per kilogram. Usually the approved transfusion trigger is defined by looking at the hematocrit and then what symptom the child and the infant is exhibiting. So there's a number of different reasons, and as you can see, a lot of it has to deal with situations in which you have cardiac situations for the baby or respiratory issues and sepsis. In addition to looking at what type of blood product we should be giving and when, we also need to figure out what type of test is required. So for preliminary testing for a newborn, the first thing that is required is you need to do ABO forward typing and using anti-A and anti-B as well as anti-D following the ABB standards, which is listed here, is what is the required practice. In addition to that, you will do antibody detection. In some situations, you would use the neonatal serum or plasma, but if it's not available, you may use the maternal serum and plasma. If it is negative, then a cross-match for the initial or subsequent transfusions is not necessary as long as group O red cells are set up. So if a situation arises where, like a directed unit, in which non-group O red cells are set up for the baby, then you do have to perform an antiglobulin cross-match on that product. If my antibody detection is positive for a clinically significant antibody, then I will need to perform an antiglobulin cross-match with red cells that are antigen negative with the corresponding clinically significant antibody. For subsequent testing, if the preliminary antibody screen is negative and it is not necessary to repeat the ABO and RH typing nor the cross-match, they may be omitted for the remaining of the hospital admissions as long as the baby is receiving group O units. So you continue this practice during the hospital admission stay or until the baby or the neonate reaches 4 months of age, whichever comes first. And this is due to the fact that infants are at 4 months of age or less or have the inability to produce red cell antibodies. Now, one point to consider is if a neonate is discharged within the 4-month period, then when they are readmitted, you have to do pre-transfusion testing just like you would for a new patient. So the next thing to consider is what type of red cells should we transfuse? And for infants less than 4 months of age, we use group O, RH negative or positive, depending upon the patient RH typing, antigen negative for the implicated clinically significant antibodies, also cross-match compatible with the maternal or the neonate serum, leukocyte reduced, or what we call CMV safe, a fresh unit, and again, this is driven by the institute. Generally, institutes classify fresh as 7 days old, and we use CPDA1 or AS3 red cells. In addition to that, we will irradiate the red cell, and we also like to test for hemoglobin S negative. So when we look at preventing graft versus host disease, it can be accomplished by irradiating the blood product or using pathogen-reduced blood products. Pathogen-reduced blood products is the newest item out on the field. It is not commonly used in a pediatric and neonate situation, so it's not used in this patient population. Irradiation is the more common way of doing this. When we irradiate, we can use 2 different types of irradiator, the cesium or the X-ray. Here at Life South, we use the X-ray. A lot of larger academic facilities use cesium because it's already been established and has been purchased, and to keep a cesium irradiator going, it's a big investment. So what you're looking for the irradiator to do is that it must deliver 25 grays to the center of the bag and 15 grays to all parts. And the way it works is that it prevents donor white T cells from replicating and then mounting an immune response against the patient. And so this prevents the graft versus host disease. It is used in intrauterine transfusions, ECMO or exchange transfusions, neonates with low birth weights, and directed donors for first-degree family members. The next area that we want to look at is CMV safe blood products. CMV is a common flu-like virus. If you're an adult here in the United States over the age of 40, 85% have already been exposed to it, and about 15% of our donor population is CMV negative. So the way it works is that they believe that the virus seems to be associated with leukocytes in blood and blood components, and so it can be transmitted by transfusions. And CMV infections can be very fatal for an immunocompromised type of patient, such as a premature infant or people with weakened immune systems. We may use leukoreduced cellular products, which are classified as CMV safe, or you might actually do CMV testing on the blood product. And again, it can, at that time, if testing is found to be negative, then it can be labeled as CMV negative. And as you can see, this is the guidelines for CMV safe versus CMV negative is institute driven based on their population and their experience of CMV products. The other part that we look at is leukoreduced cellular blood products. And it helps by reducing CMV risk, just like what we were talking about, CMV safe, reducing febrile and non-hemolytic transfusion reactions, and reducing HLA immunization. And the way this is accomplished is by taking white cells and removing them either through filtration on whole blood or by separating in an apheresis type of collection by centrifugation. So when we look at it, the bottom line, the contents for our red cells, our apheresis platelets, needs to contain less than 5 times 10 to the 6 leukocytes in 95% of the products, whereas whole blood derived platelets have to have less than 8.3 times 10 to the 5th in 90% of its blood products. Nowadays, almost all facilities are 100% leukoreduced. One other thing that is considered for this population is hemoglobin S negative red cells. And we want to make sure that the red cells do not have hemoglobin S. And the reason for this is that in low oxygen tension situations, red cells containing hemoglobin S may sickle and they cause a vascular occlusion. And this can happen in patients that are going ECMO or maybe on the cardiac bypass, preterm infants that are receiving repeat transfusions. You just want to make sure that they're already dealing with the whole hemoglobin F situation. You don't want to be adding more, contributing more to the problem by giving hemoglobin S positive units. So the way the testing is done is screening is done by using a SickleDex test kit, and we do a qualitative solubility type detecting either if the donor is homozygous or heterozygous for hemoglobin S. And then if positive for either one, they are removed out of the system and not given to these patients. When we look at the age of the red cell, we need to look and see what happens inside the bag. And as the red cell ages inside the bag, what you have is membrane leakage occurring, which causes extracellular potassium to be released out into the product. And this can be problematic for the infant as well as when you irradiate, it increases the rate of the membrane leakage to occur. So you have even more extracellular potassium. So it's important to try to transfuse the irradiated product as quickly as possible in a neonate situation. In addition to that, you will have decrease of 2,3-DPG because it is being consumed in order to sustain the red cells. So after doing a lot of studies that are out there, it is recommended that CPDA1 or AS3 anticoagulant be used because it does not contain mannitol. When we looked at the age at these different, most of it is defines it between 5 to 14 day old as being fresh. Again, a lot of institutes have gone more to 10 to 14 days, but again, this is institute dependent. And then also you need to look at the hematocrit. The CPDA1 most of the time will have an 80% or greater hematocrit, whereas AS3 has a hematocrit target of 55 to 65%. The next part of our guidelines we'll be looking at is platelets. And as you can see, we have situations where you have non-immune thrombocytopenia indications. And of course, the dosage here is 10 to 15 mLs per kilogram. So you have a number of different symptoms that the baby may be experiencing, different whether or not they're getting prepared for surgery or instability. And based on their platelet count will determine when you transfuse. These are the current guidelines that are being used at UF Health Shands Hospital. And then we also look at immune thrombocytopenia indications, and that is when a neonatal thrombocytopenia will occur when the mother has produced an antiplatelet antibody, either an auto or an allo, and it crosses the placenta and it interacts with the fetal platelets, making them inactive, and as a result, the patient may need to be transfused. The next type of product that we're going to be looking at is plasma. And in plasma, again, the dosage is 10 to 20 mLs per kilogram. There's a number of different items that you can look at here as to guidelines as to when you will transfuse. You have vitamin K deficiency, you have TTP, you have a situation where if you do not have the factors available, that sometimes actual factors are not available, then you would use various products such as plasma. And then we also have cryoprecipitate. The next product that we will be looking at is cryoprecipitate. Cryoprecipitate, the dosage is 1 ml per kilogram. Here are the different items that are listed as to why you would use cryoprecipitate in different situations. And then, of course, if you do not have a manufacturer factors available, such as factor 13, then you would use cryoprecipitate in this situation. So that's how we would do that. And with regards to pediatric guidelines, so the pediatric patient is considered a 2 to 18-year-old. And again, this is very dependent upon, you have to consider the size, because some 18-year-olds are large, they could be considered an adult. Some 18-year-olds would be more like a young teen. So you have to go back and look at the actual weight involved and the size of the patient. So the preliminary lab testing for pediatrics is the same as adult requirements, and your transfusion triggers for pediatric patients are very similar to the neonate indications. Again, the guidelines are driven by the institute. So when we look at our required testing for an infant greater than 4 months old or for a pediatric patient, it's going to be treating them the same as an adult. So the required testing would be ABO group forward and reverse, RH testing using anti-D, and then of course testing for weak D is optional, but a lot of places do it so that it can be documented in the patient's files. And then in addition to that is testing for unexpected antibodies and then determining if the antibody is present, whether or not it is clinically significant. If the antibody screen is negative, then immediate spin or computer cross-match may be done, and then provide cross-match compatible red cells. If positive, then for a clinically significant antibody, then we need to perform an antiglobulin cross-match with antigen-negative red cells to the corresponding antibody, and then of course set up those units that are found to be compatible. When we look at pediatric guidelines, one of the things we have to consider is the patient's weight, and in order for us to determine what type of dosage to be given. I have given you here a graph in which is a common graph that is used for pediatric patients as to their weight and the estimated dosage that should happen. In a lot of pediatric facilities and neonatal facilities, in working with electronic ordering processes, a lot of facilities have changed the way they order so that they're prescribing it by mLs as opposed to a component. And this is to minimize dosing errors and reduce the risk of circulatory overload if they get transfused with the various products. So this has helped a great deal into making sure that everyone is on the same page as to exactly how much should be given to the patient and doing it by mLs. I have listed here all the different references that were obtained, and like I mentioned to you, a lot of transfusion guidelines are institute driven, so this was actually pulled from a number of different facilities and their information. Thank you very much for your time and good luck on your test.